but I'm typically quite loud. So I wanted to talk about radiation advances, but I also wanted to talk briefly about breast cancer survivorship and some of the issues that come up in breast cancer survivorship that maybe as physicians we don't talk about enough. So you're diagnosed with breast cancer and you are completely overwhelmed, you are bewildered, you have no idea what to do. You meet with your doctors, they tell you what your treatment is, and you do everything that you were supposed to do, and you're a survivor. And you've gotten through it, and life should return to normal. We're going to come back to this, but this is what I want to emphasize. As we move forward in our research and our breast cancer information, we really want to emphasize that not one size fits all. And so the treatment options that we present now are really trying to give an individualized approach to every woman. So not every woman will need surgery and radiation, or surgery, radiation, chemotherapy, hormonal therapy, and reconstruction is an option too, but every woman will have a different treatment plan depending on her cancer and her biology. So as a field, I think we are all moving away from one size fits all. And if you apply that to the different advances that have been made, if you look at surgery, as was just discussed, we've moved from mastectomy to breast conservation to skin-sparing mastectomies. If you look at medical oncology, we've moved from chemotherapy or even treating with hormonal therapy to treat hormone-sensitive breast cancer. And then what I will discuss further is from radiation, we've moved from whole breast radiation to partial breast radiation or even prone breast radiation. And each technique that we're going to discuss is basically an effort to try to spare as much normal tissue as possible in terms of the heart, the lungs, and what have you. So when I think of inventors, I love Einstein, and I love this quote because it says, there's only two ways to live your life. Basically, as though nothing is a miracle or as though everything is a miracle. And I like this because I think that while it may seem slow, I feel like the advances that we're making in breast cancer, we are taking leaps and bounds. So if you talk about radiation, a lot of women have a lot of fear when you mention radiation, especially if they were treated 20 or 30 years ago. The radiation of those days is not the same radiation that we give now. But admittedly, before we were using CT-based planning, there was more heart and there was more lung in the fields, and potentially there was more toxicity in terms of cardiac morbidity and mortality. The newer techniques involve CT-based planning. Number one, all techniques involve CT-based planning, so we are always aware of how much dose each organ is getting, and every organ in the body has a tolerance dose to radiation specific to that organ. So we are always making efforts to stay below the tolerance dose of the heart, or stay below the tolerance dose of the lung. In terms of new techniques, where we are looking at prone radiation therapy, accelerated partial breast radiation, where we're giving treatment in 5 days and just treating the tumor bed, and intensity modulated radiation therapy, where we're basically telling the computer, this is the tissue that we want you to treat. We want you to treat the breast, and we want you to minimize as much dose as you can to the heart and the lung. Come up with a plan. So in terms of radiation advances, the traditional technique is to treat patients supine, and this is normally a 5 to 6 week treatment, Monday through Friday with your weekends off. Now we're moving more towards prone radiation therapy for the appropriate patient, where a patient can lie on their stomach, and the idea of this is that if you're prone, if you're on your stomach, the breast tissue is falling away from the chest wall, so potentially there is less lung and less heart in the field. Now it is not an easy position to get into, and that's why I say it is for the appropriate patient. Potentially patients with smaller breasts may not benefit as much from this. And both of these techniques are treated on our traditional linear accelerator. But if you look at these CT slices for prone irradiation versus supine irradiation, if you look at the supine irradiation, you can see that there's a lot of lung in the field. And that's because we want to cover the chest wall. That's because we want to cover the chest wall. And although you can't see it in this slice, there's going to be heart in this field as well. Not intentionally, but the heart is beating. So as much as we try to block it out, we can't block it out completely. If you compare that to this prone breast radiation, you can see that the patient's breast is falling forward, and there really is hardly any lung in this field at all, as well as any heart in this field. Partial breast radiation is not new. It's actually been around for quite some time as well. But the techniques are getting better, and the results are getting better. So if you look at partial breast radiation, we can do it with something called brachytherapy, where you're actually putting a balloon in the breast, either at the time of surgery or say about 2 weeks afterwards, and you deliver radiation through this catheter that's sticking out of the breast 5 days, twice a day. And it's just treating the tumor bed as well as about a centimeter to 2 centimeter area around the breast. Partial breast radiation can also be given on a traditional linear accelerator. The margins are a little bit bigger, but it's still a 5 to 10 day treatment, so much less than the 5 or 6 weeks of traditional radiation. And again, all efforts are to spare as much normal breast tissue as possible, as well as sparing the lung and heart if it's a left-sided breast cancer. Cosmetic results for this type of partial breast radiation have actually not been shown to be as impressive as with the balloon. And then we have one more technique that we're actually offering, which is partial breast radiation with stereotactic breast or stereotactic body radiotherapy. And this just happens to be a CyberKnife. And it's the same idea as the other two techniques, except that instead of using a balloon or using a traditional linear accelerator, this linear accelerator is on a robotic arm. So there's no limitations in terms of the range of motion or the angle that it can approach the breast. What's more is there will be fiducials in the breast, and so as you are breathing and the breast is moving, this machine is actually moving with you, tracking those fiducials, so you can use a very small margin and give a very high dose without worrying about missing the tumor. So is newer always better? I think as oncologists, as doctors, we always have to ask the question, and that's why a lot of these advances are always looked at on trials or protocols first. So we know that with prone radiation, as stated before, there is a reduced amount of lung and breast and lung and heart in the field. And there was a study that came out in 2012, a prospective randomized trial that looked at 100 women, and it showed that the majority of these women, I think all the lung was out of the field in 100 of these women, and about 90% of these women, the heart was out of the field. So this is progress for the appropriate patient. Prone breast radiation is not for everybody. So if it's a more locally advanced breast cancer and we have to treat the lymph nodes, then prone breast radiation is not ideal. In terms of partial breast radiation, we have 12 years worth of follow-up that shows that partial breast radiation gives equivalent results in terms of local control to whole breast radiation with similar patterns of failure. So what I say when people ask me, isn't this better or is this technique better? None of these techniques are superior. It really depends on the actual woman, the individual, the shape of her body, and her actual disease. So the results are equal, but it's just too early to say that one is better than the other. Maybe as the data matures, we'll move towards one technique over the other, but right now I think we have a great arsenal in terms of what we can offer women. So the next step would be to combine prone breast radiation with partial breast radiation, and we are actually looking at this as well. A study came out of NYU where they looked at about 100 women given prone partial breast radiation. They were all postmenopausal. The treatment was given over 5 days, and what they found was that in terms of an in-breast recurrence, after 5 years, there was only one. In terms of an in-breast recurrence with concurrent distant failure, there was only one. So in terms of local control, prone breast radiation given with partial breast radiation was very feasible and gave great results. And in terms of toxicity, if you look at the toxicity, there was really mostly just grade 0 toxicity in terms late-term side effects. Very few women had any sort of long-term fibrosis, edema, or fat necrosis. So this is also a great option for the appropriate patient. So now what? You're a survivor, you are celebrating your survivorship, you feel great. You should feel great. But at some point in time, you probably have to sit down and ask yourself, what's normal now that you've gone through this diagnosis? How do you see yourself? How do you feel about your femininity, your identity, your sexuality? What is your actual new normal? Survivorship is actually defined as any individual diagnosed with cancer that is still living. So from the point of diagnosis, you are a survivor, and you should celebrate that, even if it's difficult, even if you resent having had the disease. From the minute you are diagnosed, you're a survivor, and that's the place that you need to stay. But survivorship looks different for everybody, and we know that despite these advances in technology and these advances in treatment, it's not without its cost. And so long-term side effects, you might notice that there are issues in terms of your emotional health, your sexual health. There might be psychosocial issues that continue to follow you. Now, the majority of actual long-term survivors feel that their quality of life is comparable to their life prior to diagnosis. So many survivors across all cancers do feel like their lives return to normal, but not everybody. And so we do know that age, race, socioeconomic status, and gender are all predictors of future quality of life. If you look at younger patient populations, they tend to have poor emotional functioning after a cancer diagnosis. Minorities and patients with lower socioeconomic status tend to have poor physical functioning, and 20 to 30% of breast cancer patients will have sexual dysfunction. And this is really something that we're not necessarily discussing. So as we make these advances, we now have close to 3 million breast cancer survivors, and that is fantastic, but what that also means is we now are more aware of the psychosocial long-term side effects of having this disease. And so we have plenty of data that shows that a lot of women will have trouble with anxiety, cognitive dysfunction, decreased satisfaction with life, fear of recurrence, post-traumatic stress disorder, and sexual dysfunction. We're not going to talk about all of the potential psychosocial issues, but let's just briefly touch on sexuality. So sexuality is central to a person's sense of wellness and self-concept, and when you tell a woman that they have breast cancer, her breasts may be very much a part of her feminine identity. It's, every woman is different, but many women would rather die than lose their breasts. It's different for every woman, but we don't necessarily address this when we're talking to you about what your treatment is and what's the best way to get you past this. And we're certainly not necessarily talking about this once you've actually completed your treatment. So body image is very integral in terms of your concept of sexual health. And body image is a mental picture of the physical self, and it includes the perceptions regarding one's physical appearance, state of health, and sexuality. But body image is actually very skewed. So if you look at what women consider the ideal woman, you see that it's not one woman, right? We can't figure out who we'd actually put up here, so we had to take body parts from different women. So you have Gwyneth Paltrow's stomach, Elle Macpherson's legs, Jennifer Aniston's breasts. And if you compare what women think is the perfect body, you compare to what men think is the perfect body, it is very, very different. And again, it's still not one woman. It's Kim Kardashian's breast and Kelly Brook's hips and Megan Fox's face. And I put this slide up here just to emphasize that unfortunately what we think is perfect is unrealistic. This is not, neither of these images are of one woman, because that woman just doesn't exist. So our idea of body image is slightly skewed, and it's not necessarily our fault, because the media does bombard us with very unrealistic expectations about what a woman should look like. Sort of sexual dysfunction. The influence on sexuality, the studies have shown, has been shown to be persistent. and often does not necessarily return to baseline or pre-diagnosis levels. And I think it's important to discuss this because if we're not acknowledging it, it certainly will not get better. Predictors of sexual morbidity also include women who have had mastectomy and post-treatment weight gain. So when we look at studies in terms of quality of life and sexual function, I like this study because it's a matched pair analysis of about 186 early stage breast cancer patients between the ages of 25 and 45 compared to about 200 women that did not have breast cancer. The participants were sexually active. They had to have had their treatment about a year prior to, although most were about 2.5 years out. And this study actually looked at self-esteem and sexual functioning. And what they found was that 57% of the breast cancer patients experienced problems with lubrication, 53% experienced problems with satisfaction, 37% experienced problems with arousal, and they did associate hormone-treated patients with a higher likelihood of having sexual dysfunction. But in conclusion, they found that patients had a significant quality of life impact because of their disease, and it did affect their sexual function. If you compare the control, these are the women that did not have breast cancer, to women who did have breast cancer. Women who did have breast cancer had lower scores in terms of desire, arousal, lubrication compared to women that did not have breast cancer. If you actually divided these women and looked at women who had radiation and chemotherapy, chemotherapy and hormonal therapy, and then chemotherapy, radiation, and hormonal therapy, this group actually did the worst in terms of their sexual functioning, their desire, what have you. So I say this to say that although we can treat you, it's certainly not without a cost, and I think that if we can start the dialogue, potentially we can start to improve some of these issues as well. So when they actually looked at the women, self-esteem levels were not different. Sexual functioning was different, but self-esteem levels were not different. And a few limitations of this study that I wanted to point out was that it did not take into consideration the sexual dysfunction of the husband. So arousal, desire, lubrication, some of these things you can't get there on your own. And so depending on who your husband is, you may have had issues with that prior to. It also didn't take into consideration the menopausal status of some of these women. It was also based on an Iranian population, so you also have to take cultural nuances into consideration. So is there a quality of life difference between mastectomy and breast conservation? This is very controversial and there's conflicting information, but many studies will say that mastectomy patients do have a poor quality of life or a body image or sexual dysfunction compared to their counterparts that have had lumpectomy. There's a lack of improvement in quality of life in mastectomy patients over time, and across the board, if you looked at women over the age of 70, they actually had less improvement in quality of life whether they had mastectomy or breast conservation. So why the increase in prophylactic mastectomies if potentially mastectomies do impact a woman's quality of life? The data shows that mastectomy may have a more negative impact on body image, but the goal of most cancer treatments is organ preservation. So ideally, if we can and if you're comfortable with it, we'd like women to keep their breasts. This is not the right option for all women, but this is the goal, organ preservation. If patients do not have a genetic predisposition, we have to ask, do prophylactic mastectomies benefit or hurt the patient? Admittedly, risk-reducing surgeries do decrease your risk of breast cancer. That's not what we're getting at here. They decrease your risk of breast cancer. If you have your ovaries removed, that decreases your risk of breast cancer and gynecological cancers. But if the decision is based out of fear and not necessarily an informed decision, is it helping the patient? I do think that some of the reason you're seeing a drive towards mastectomies is the beauty of new, or the beauty of new breasts, because what the plastic surgeons are able to do now is just astounding, and women have more options in terms of either having implants or an autologous implant where they pull money from your latissimus dorsi, or they pull a tram flap, or they pull muscle from your abdomen. So breast reconstruction complicates the schema in terms of if women are having mastectomies and they can have breast reconstruction, do they then return to their baseline? Do they still have these issues with body image or sexuality or mental health? And it's mixed results in this field as well, because some studies do show that no matter when you've had your reconstruction or what type of reconstruction you've had, you still do feel distress several years later after having breast cancer. But then there are more, more recent studies that show that women are very happy with their reconstructions and very happy with their decisions. So all this to say, it's just very individual, and while you can talk to your friends, it will always come down to a decision that works best for you. And I put this slide in here just because I was reading a New York Times blog, and I called it the nipple whisperer. I don't know if anybody else actually saw this article, but when you have your reconstruction, a lot of times to finish the surgery, you have to have a skin graft to have your nipples done. And by this time, depending on how many surgeries you've had, women just don't necessarily want to be cut again. They've had enough. Tattoos are an alternative, but a lot of times women aren't necessarily happy with the tattoos that the plastic surgeon does. And so this tattoo artist, Vinnie Myers, I think he's out of Finkelberg, New York, he actually has a 6-month waiting list for nipple reconstruction because he has perfected the 3-dimensional areola. So I just wanted to throw that in there. So when you think of survivorship and you're celebrating survivorship, you still have to do all the things in terms of prevention that you would if you weren't a breast cancer survivor. So you still have to eat well, you still have to exercise. All of these things help reduce the risk of recurrence. Acknowledge the individual issues that you had while going through your treatment and make sure you're following up with your physicians. And try to take a proactive role and really just choose to live healthy, as goes across the board for everyone. But we know that no more than 1 drink a day for women and no more than 2 drinks a day for men will help decrease the risk of cancer. Moderate physical activity is associated with a 50% reduction in death from breast cancer. Avoid excess weight gain, and very simply, as our mothers would say, eat your vegetables.